Good evening, everybody. Welcome to our Callan General Practitioner Primary Healthcare webinar. I'm very excited to be part of this, and thank you to Jackie O's, our invaluable GP liaison colleague who has invited me along. So my name is Jerry O'Callaghan. I'm the Executive Director of Medical Services. And before we go any further, I would just like to acknowledge that the land that we meet on today is the traditional home of the Ghana people, and that we respect their spiritual relationship with their country. We acknowledge the Ghana people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are as important to the living Ghana people today. And we pay our respects to the cultural authority of Aboriginal people watching or attending from other parts of Australia. I grew up in a household of regional general practice. My father was a GP, my brother is a GP in Ireland, and I have no doubt that GPs are the bedrock of the healthcare service that we provide to the community. So this is an important conversation. I'm really delighted to be part of it, but I am not the content expert in the room tonight. So I'm going to defer to my colleagues, Jess Hafner, our consultant neurologist, and Jackie O, who leads our liaison effort with our primary healthcare stakeholders, and a little later, Andrew Van Lint, who's been our chief resident for the last 2 years and chair of our TMO forum, is going to talk to you about the work he's done in relation to handover of care back to primary healthcare for inpatients. So without further ado, I'll pass over to Jess.
Thanks, Jerry. So I've been asked to talk to you today about waitlist management. I know that the lengthy wait lists for public outpatient services are a source of great frustration to GPs, patients, and clinicians within the hospital. All of us get very frustrated by those wait lists, and so we've been working hard to try and improve the way that they work, and I've been particularly focusing on the neurology wait list, which is notoriously sort of catastrophically long, with patients waiting several years for clinic appointments in our service. So what I'm going to talk to you about today is really just what we're doing in the neurology waitlist space, and that's something that's kind of being expanded across other services. Go to the next slide, please. So historically, what has been happening is that all the referrals to our service were generally, with very few exceptions, accepted onto the wait list, and they get categorised by a clinician, which within Callan is a consultant level clinician, to either being urgent, semi-urgent or non-urgent. And you can see there on your screens the sort of the time frames that those categories applied to. The problem was that very quickly, many years ago, those timeframes became sort of unrealistic, and something triaged as a semi-urgent referral in reality would wait 6 to 12 months before they were seen, and there are cases where that has been even longer. Occasionally referrals were declined, or the referral would be asked for additional information, or the referral might be redirected if the patient was sort of out of area, but a lot of the time those things didn't happen. And anything that what those categories were, there was no clear criteria, so it was very much up to the clinician on the day deciding whether they thought it was urgent or not. And there was a bit of a culture that anything that wasn't clearly a category 1 or category 2 would just get triaged as a category 3 rather than being declined. So even something that probably wasn't suitable for the service would just still go on the wait list, and you can imagine that that resulted in the wait list blowing out. We'll move on to the next slide. So here's just some stats from when I was reviewing the situation back in October last year, prior to this forum originally being planned. So at that time, at the end of October last year, there were 1,912 patients on the waiting list for neurology outpatient services. The vast majority of those, 1357, were waiting for general neurology, about 200 waiting for epilepsy, and about 300 waiting for other subspecialty clinics. And then there were sort of 14 referrals sitting on the wait list that in sort of odd spots that didn't quite make sense. And then looking at the time frame, you can see there those second two columns on that same table. 800 had been waiting for less than a year, but you can see that there's a very large number of patients who've been waiting more than a year for a clinic appointment, and some of those even waiting out past 4 or 5 years. And just trying to work out how we deal with that backlog. In the same month that I got those stats, I looked at the number of clinic appointments that had actually occurred within Callan. The number of clinics we run varies week to week depending which consultants are on looking after patients in the hospital on ward service, and clinics get closed, people are away. So I just took a month as a sample of what actually happens. We only held 16 new neurology appointments in October. So looking at that general neurology waiting list, even if no one ever got added to that waiting list again, it would take us 84 months to clear that list. So you can quickly see that maths is just not sustainable. We get, just down the bottom there, I've added in, we're getting about 20 to 40 new referrals. I think that's per week. We've got our video blocking my slide. I can't quite see what it says, sorry. So that's 85 to 170 a month. So between 1,000 and 2,000 a year is being added to that existing waiting list. So something needs to change in the way we manage our lists. Yeah, next slide. So the way that we're doing this in neurology is that we're undertaking a clinical review of all of the wait-listed referrals, which is a fairly onerous task, but that's being conducted at a sort of consultant clinician level so that the quality of that clinical review is robust. And letters are being sent to referrers to request updated information or additional information if the original referral didn't contain adequate information to make decisions. And some of those referrals are being declined because they don't actually fulfil the criteria for our clinic, which I'll mention in a moment. When we do decline a referral, we are trying to provide some sort of guidance or advice to the referring doctor because we understand that obviously if a referral's made, it's because the referrer feels they need help with the problem. And so declining a referral without providing any guidance is unhelpful. And I know that sometimes does occur, and we're working hard to try and make sure that it doesn't occur. And where possible, we're suggesting alternative referral pathways or providing suggestions on primary care resources, such as references to therapeutic guidelines where that's appropriate. And then we're giving, this is in reference to people already on the wait list, we're giving a 90-day time frame for that referring doctor to get back to us to let us know if there's anything specific that we've missed or that we haven't understood. And we're also notifying the patient and advising them that they need to make an appointment to see their GP so that the GP has that up-to-date information. So far, that's been underway. That process has been happening now for more than 12 months, but it's a very slow process, as you can imagine. And approximately 50% of the referrals that have been reviewed are able to be safely removed or redirected. And I just did a calculation today. At the moment, we're standing at just over 200 referrals have been removed from the neurology waiting lists, many of those since those original numbers, which is pleasing. Next slide. But obviously we need to stop this waitlist reaccumulating, and so to do that we have now developed quite clear criteria for the neurology outpatient service, and these criteria are available on the internet. Unfortunately, because we have so many subspecialty clinics within neurology, the criteria are quite onerous, and I can imagine as a GP on a busy day, you probably don't necessarily have time to sit there and look through those things in detail. But hopefully over time, as you're referring and getting feedback on those referrals, you can become increasingly familiar with with those criteria, and if you have time to look at them, they are there available for you to see. We've tried to make them as clear and concise as possible, but it is still a reasonably lengthy document because of the number of different clinics we run. The aim of this is also to help our clinicians as we're triaging, to improve the quality of our triage and to make sure that we're more consistent, that your referral doesn't get processed sort of depending on who is triaging it, that it's much more consistent across the board. And I'm working very hard to try and change the culture of triaging things to a category 3 if there's something that's not suitable for the clinic or that the clinician's not particularly interested in. This culture of just making that non-urgent is really unacceptable, and we're working very hard to change that culture, which has been there historically. Next. So that's the short web address that you can use to find the neurology criteria. And you can see an example there of the epilepsy and first seizure clinic criteria. So you can see it is quite long, but hopefully it's comprehensive and gives you a really clear idea of the things that will and will not be accepted to the waiting list. And if you're able to look at that before you send the referral, hopefully in the long run that would save everybody a lot of time. So there's lots of other ideas in this space, and I think we've still got heaps of work to do to make this work well, and a lot of that needs to happen at our end, and it's going to be a bit of a learning process for both of us, both GPs referring into our system and also us learning how to deal with changes in the system. We're hoping to develop an electronic referral system because at the moment we still rely, unbelievably, on the fax machines. Which is clearly a serious weak point in terms of things being lost and GPs not getting any feedback on whether their referrals have necessarily been received. And so we're hoping to be able to eliminate that risk, and also to allow some sort of real-time feedback to GPs. So if a referral comes in, being able to communicate that quickly, what extra information we need to be able to triage that referral or provide advice to help the GP manage the patient in a timely fashion rather than using snail mail, which is currently what we're using most of the time. And we're also I would really love to see the development of a better sort of no review required advice system. So what I mean by that is, for example, when you see a patient in clinic who's had headaches and you've done a scan and there's some non-specific changes there on the MRI, you're just not sure what to make of it. Often those patients don't need to physically come and see us in clinic, but we can have a look at the scan, we can chat to you on the phone, give you some advice about whether or not there's anything else that needs to be done. That currently relies on phone calls. GPs are too busy in their day to be waiting for the switch to pick up to talk to some registrar who then doesn't know the answer. It's a really inefficient system relying on phone calls. So it'd be really good to have some sort of electronic secure messaging service so that we can communicate with each other at times that suit us and give that advice, and your patients don't even go anywhere near a wait list. But this is all to come. It's all it's still in the pipeline. And yeah, that's everything from me. Thanks. I'll hand over to Andrew.
Hello everyone. I was in Callan for 7 years, and I'm enjoying my second week in Nallan. So special welcome to those who are crossing network borders like myself with your own work. I'd like to talk about a project that I've been very excited about that is coming close to fruition now, and it's been a very close partnership between the Callan network as well as general practitioners in that region and others. And it's about discharge summaries and that important clinical handover that happens at the point that a patient goes home and returns to their GP care. Next slide. So the big problem, I'll just go to the next one, is that currently, as with a lot of documentation, we don't have a clear defined audience for the discharge summary. We don't have a clear structure, and we don't dictate what kind of content should be in there. Some units do this really well, and I particularly want to recognise Dr. Hafner's unit, Neurology. They give very specific instructions to their junior staff and their consultants on a weekly basis review their discharge summaries, which is quite a rare treat, I think, in terms of quality control. But for most units, they're not able to offer that level of supervision and direction. So we've worked with general practitioners to produce what we hope is a very efficient but high quality template that we're hoping to be used across multiple units. And there's some of the feedback and some of the issues that are summarised there. Next slide. So this is the process. We determined a purpose and audience. So that's general practitioners, number one, and number two being the patient and their close contacts. We drafted a format based on the ISPAR format. So that's introduction, situation, background, assessment, and recommendations, which is a clinical handover tool used across the world. We then used a digital focus group to work on that. There's one or two participants of today's webinar that participated in that, and I thank you for that contribution. We then did some refinements based on pharmacy input as well as a few other specialists, and then we took that out to consumer review, and we did a pilot in November of last year at the Queen Elizabeth across 3 units, and then have evaluated that, and I'm quite keen to share with you a couple of highlights from the evaluation. Next slide. Next slide. So as I said, primary audience is the GP, and the real purpose of that, rather than being, sometimes some people say, well, the purpose, of course, is to summarise the admission. That's why it's called a discharge summary. I'd actually argue that the purpose is probably better served to say this is a clinical handover. As part of that handover is a form of summary of the admission. Next slide. So what we wanted to do is have a very clear format. We recognise that all of us, specialists and general practitioners, are lacking in time, and we want to have a very succinct summary that clearly outlines the major events, medications being identified as a very important point of safety and continuity of care, and a clear discharge plan with who should be specifically responsible. And ideally that general practitioners and specialists alike can read this document and quickly find the specific information they need without having to trawl through a lot of excess data. Next slide. This is based on the GP feedback, and that's kind of some of the points I just alluded to. You know, specifically why were medications changed and what was they changed to and from. Key investigations instead of just a ream of every blood test they've had at discharge and admission, and specifically contact details for who you can call if you want to get more information from that discharge, instead of just a generic unit, please call switch, and then you're getting put on hold. Next slide. So this is the summary of the structure that we had there. So we said the situations, why do they turn up to hospital? The background is their past medical history. The assessment are the key issues and the management decisions during admission. The recommendations is focused around the discharge planning. So where are they being discharged to? Are there outstanding investigations, and who's going to follow them up? What is the hospital doing to follow up this patient's care? And what are we asking the GP to participate in? And we talk specifically around the language that we want to use. The common phrase that comes up is say, GPs are not dogs. We don't chase things on demand. And I think things like we are requesting, could you do this for this reason? I think that kind of respectful language between professionals is really important that we're emphasising. Next slide. So I've just alluded to some of those general principles, and minimising acronyms. I don't know if you've ever had, whenever I moved to a different specialty, I discovered they've got all these different acronyms I've never heard of before. I particularly remember moving to obstetrics and gynecology, where again, they've got a huge number. As a trainee interested in clotting and bleeding, PE to me means pulmonary emboli. PE to a gynecologist means preeclampsia, very different kind of entities there. So what we're trying to say is acronyms should be minimally used. We try and avoid specialist terminology in the shorthand, and making sure the language is non-judgmental and easily read by non-specialists and by the patient and family. Next slide. So we outline the presenting complaint, and we specify that we don't actually want to include examination findings. They're not usually of great interest to general practitioners or the hospital. or the medication list at the time of admission, or the initial investigations unless they're defined as key. Next slide. And then the assessment, there's a few specific things that we wanted to include. There's a lot of named of like treated with antibiotics. I don't know if you've ever got summaries like that or letters. We're actually saying whatever antibiotic you use, please specify it, because there's a lot of useful information about what should be continued, what's worked for that patient with that kind of infection in the past and what hasn't, and also about allergies. There's a lot of patients out there with penicillin allergies, and being able to quickly find, oh yes, they have tolerated ceftriaxone or Keflex in the past is really helpful, both from the hospital and the primary care perspective. Next slide. And this is where we really outline very specific discharge plans, outstanding investigations, what's the hospital offering, what are we asking the GP to follow up, and who can be contacted from the admitting unit for ongoing information. Next slide. So we defined key investigations as being critical imaging or pathology. I think most people agree those are the things that people want to see. They were diagnosed with cancer. Okay, well, what kind of cancer? What did the report actually say? Oh, you had this scan that changed management. What did that scan actually show? Because if I repeat a scan down the track, I want to be able to compare those changes. I want to request specifically the information that I need to know. And avoiding routine bloods, certainly as an intern, when I wasn't sure, I often just ticked the bloods either at discharge or admission, and I've since really learned that's not particularly helpful, and it's usually just wasting paper. Next slide. So this is the pilot. We'll go to the next slide. We trialled across cardiology, upper GI, and gastroenterology. Admittedly, there's a bias towards these procedural-based specialties that was unintentional, just that those 3 units are were very open to participating. We did an online education program for the junior doctors, so the interns and residents in those units that do the discharge summaries. And then we audited, and many thanks to Jackie for staying up late at night and on the weekends, did in total 120 discharge summaries were reviewed using a quality tool that was really constructed from what GPs defined as quality, with a little bit from the hospital perspective. We also did a brief trainee medical officer feedback, and we're going to do a follow-up survey, which if you're interested in this space, you can email me later. Next slide. Next slide. So this is the summary graph, and you can see on almost every single area, the new format outperformed the pre-pilot non-described format in almost every area other than antibiotics, specifying the antibiotics used. And that's because across all of those 60, there was only a handful that actually had antibiotics involved in the discharge summary. So that's more of a low data issue rather than a lack of performance there. So that was very encouraging that, we set a target with GPs in mind. We defined the quality in partnership, and then the template that we produced really performed to what we wanted it to do, which was very encouraging. Next slide. So the junior doctors, we were worried this might take more time, or if we were lucky, save time. We found on average it basically didn't change the time, but the overall comment was that the time was being used in a more focused way and actually helped clarify some issues at discharge, which was a real positive. They felt that in terms of the clarity of what was expected of them to put in terms of structure and content, there was a clear improvement there. And in terms of ease of use of the template, that was relatively easy as well. And they particularly commented that, being asked to define the rationale for medication changes and the responsibility for follow-up was very helpful. And we talked about doing a very shortened version for procedural-based admissions that are just day of surgery or just for specific cardiac procedures, and that's another side project that's going on. Next slide. So we, at this point, before we look at very seriously rolling this out across the Callan network, and there are other networks interested, we are doing a GP survey which involves looking at some pre and post pilot de-identified summaries and asking some questions about that. So if you are interested in this space, which I think you might be because you've joined this webinar, I think there's a bias amongst this group, please email me if you're interested, and I would love to send you The survey, it's just an 8-point survey, and there are 6 discharge summaries to read as part of that. So it's not meant to be onerous. So if you're interested, please join that. I'm seeing what is the education piece to complement the rollout of the discharge program for both those in medical and the public domain. The education piece, I can comment internally. We've done a video-based education, and there's a template as well as an acronym expansion. So within our electronic system, they can literally just put .discharge, I can't remember what it is, specifically, and then the whole template structure appears in the discharge document for them to then fill in the spots that they need to. So if you participate in this trial, or if maybe if you're working in the West, you may see some of these summaries already. They have a very specific structure that's easy to follow, and hopefully that makes it very easy to find information on demand. I'll hand back over to my esteemed panelists. Thanks for your time and attention.
Thank you, Andrew. And for those of you who haven't already met me or spoken to me or emailed me, I'm Jackie Yeo, the GP Liaison Officer for Carlin, and I was going to try and do an interactive thing, but we'll see how we go with the technology. Before I do that, I just want to say I did a presentation on Andrew's project yesterday to our Quality and Safety Executive meeting, and I find those discharge summaries much easier to read. Initially, when I started auditing them, I wasn't quite sure what I was looking at, and then I got to the ones that did have the new format, and I thought, oh my goodness, this is such a difference. So I'll be very interested in hearing GP forward feedback, but I also want to know what you find useful, what you don't find useful about them, so we can make sure that they meet your needs. So yes, thank you very much to anybody who is prepared to do that. We really appreciate it. And feedback is always welcome. If you can't think of anyone else to send it to us, please, because we'll find places to send it to. Trust me on that. So coming back to the bit that I'm talking about, which is how to find your way around our websites. They're horrible, aren't they? They really are quite difficult to navigate, and I know a lot of people get very frustrated with them. So what I want to do is to teach you how to jump off from the Royal Adelaide website. So as you can see at the top, it's www.ra.sa.gov.au. And when you go to the front page, you'll see a banner that comes across the front there that says patients and visitors, health professionals, support us. Don't go to patients and visitors. We love you being supportive, but please go to health professionals, because that's the bit that's going to help you the most. I don't know if we're going to be able to share the next bit, but if we can't, what we will, thank you, Lauren. That's fantastic. So what we will do, if we can't get this to work, is we will videotape me doing this. I'll just talk you through it. If any of you want to look at it on your screens as we're speaking, please go right ahead. So in the middle, we've got GP Liaison. Obviously, that's the GP Liaison unit. There are useful things on that. The first thing that I can tell you about that's useful on there is you'll find our direct contact number, our direct contact email, and you'll find a little bit about us. So yes, as you can see, we've got the direct contact for our GP Liaison nurse, and that will be either Bree or Christine, our 2 lovely nurses who are just fabulous in this role, and they're there from 8 o'clock till 4 o'clock in the afternoon. And they're quite happy to take phone calls, and I'm sure many of you know them already. My email is on there as well, and my contact number, and you're very welcome to ring or email me. I don't work on Mondays and Wednesdays because I'm now doing general practice, so it's probably better not to ring me on those days. But if you do, leave a message, I'll get back to you. It's fine. Down bottom, we've got the GP Carlin link, so you can sign up, and we will send you lots of interesting things about what's going on in the Royal Adelaide Hospital. So that's us, and as you can see, we've got the email address over on the side, and we are quite happy to get emails. You don't have to send us a signed letterhead unless if this is a patient who's new to your clinic, in which case please do send us a letterhead with the patient's signature so we know we've got permission from the patient, because otherwise it gets a little bit tricky, because of course we're going to have consent. So that's us. So if we go back up to the top, and as you can see on the side there, where it says also in this section, there's 2 ways to get to this. You can either go back to health professionals and toggle back, or on the side there, you'll see there's clinical services, GP liaison, and outpatients. Or if I can get you to go to outpatients next. There we go. And if we go down on that screen, you will find several things. One, there's a section on urgent and serious outpatient referrals. we'd really love you to ring about these ones. The reason being fax failures, and unfortunately with the rollout of the NBN, we have a major problem with faxes not getting through to our referral hub. We also have problems sometimes with getting faxes out to you guys, and I apologise for that. There's nothing we can do about it as a hospital. I'm afraid that's out of our control. But if you ring and you tell someone that you have an urgent referral, and I've done it many a time myself, you should get a really good response. They may not always think it's as urgent as you do. That's okay. They should be able to talk you through what you can do with that patient and how to proceed with it. If you're having problems with that, can you please let me know? If you're really having problems with the registrar, you do have the option of calling the consultant on call, and I'd rather that you did that and got things sorted out, but please ask for help if you're having problems with it. It is so important that you just hand that over to someone, because that way we can be absolutely certain that we know and that referral does not go missing. For all other referrals, and if we go down now, the one really important, well, there's lots of important pieces of advice. Please don't ring the 1300 number. You'll go mad. You really will. You'll be sitting on hold, and I'm going to get in trouble. I know comms are thinking behind me, oh my God, she's saying this. Don't do it. Don't tell your nurses to ring it. Don't tell your admins to do it. You're on hold for ages and you won't get through it and it'll drive you nuts. Please ring the referral management hub. They are lovely people. They're our assistant nurse unit managers. They are really, really good value. They will help you navigate outpatients if you're getting stuck. If they can't do it, they'll point you in our direction. We will help you to get it. Please be nice to them, because they'll be nice to you if you're nice to them. Just as we need to be nice to your reception staff. It's professional courtesy, isn't it? The other thing I'd encourage you to do is, if you can, email in your referrals. Now, the RACGP says if you have the patient's consent and you've documented that consent in the notes, and what I say to my patients is, look, it's not secure, because as yet we haven't got secure messaging. Now, I have been involved in writing the very first electronic referral form, and it is coming. Probably not this year, but hopefully next year. We've done the referral form. Now we've just got to get the process in place. But that is definitely coming, and that will be secure. We haven't got it yet. But if you email it in and you explain to the patient it's not secure, there is a small chance that somebody may hack into your email and they may discover your information and sell it on the dark web. My patients usually look at me and go, why would they want to know about my Parkinson's / whatever it is? And my son just looks at me and rolls his eyes. So it's never happened to any of my patients, but I actually make sure I document it, and that covers you. And if I've got a patient who says, no, under no circumstances do I want that, it's fine. We just don't do it. But please, if you email them in, A, you can ask for a receipt. B, you can be sure they've got to us. So it is actually, I think, a better way. And our practice is now emailing in all our referrals. I know Oliver Frank, who's listening to this, is also emailing all his referrals too, which makes me confident that that's working well. You can fax them in. If we go down further, there's two things I want to show you. The first is, just stop there for a moment, Lauren. If you see there, it says, for more information, view the Royal Adelaide Hospital contact list. If you click on that, you will bring up a PDF. And if you go down, you're not so interested in that bit, but if we go down through here, we've got all of the numbers for the nurse unit managers and the referral hub. The ANUMs, the assistant nurse unit managers, are on there too. So that is gold. If you go down even further, we've got some numbers for various other things as well. Now, I'm sure you all remember from when the Royal Adelaide moved to the new Royal Adelaide, and there were no numbers of any sort except for the switch number, and it drove us all nuts. They're there. You can use them. You just need to look a little bit further. So please do use those. They'll be very helpful in getting you to the right place. And if they're wrong, please let me know, because we can do something about it. So if we go back to the page that we're on before, and then just down a little bit further, and you probably know about this already, but just so we know for sure, the services that we've got down underneath are all services that don't want you to send to that 70746247 number. We don't have so many problems with faxes coming in with those numbers, and you can click on each one of them and it'll give you a drop down. They're not so much of a problem. It seems to be the referral hub that's the main problem, and I'm no technologist, but it's something to do with the handshake between a big thing that spits out faxes I'm going to sound like an idiot, Bree would know far better than I. Anyway, it's to do with the fact it's a big thing that spits out things in various places. Don't worry about that side of it. So that's great. If you go over to the side, Lauren, and I just actually want to have a quick look at the spinal one. So if we go down a little bit further, just under there, and I just want to bring this up because I want to show our GPs what they can find. On that side bit, most of the outpatient services have things that are useful to you. Not all of them have got things there yet. We've got to get plastics, ENT, and there's some neurosurgery and some others. We will get pages for them. But if we go down further, you will see, I just want to show the printable version. Yes, thank you. And I want to talk about this one very quickly, and then I think I might actually finish off, or I'll tell you very quickly about clinical services. Now, if we go down even further, so scan down to the bottom of this form, this is the infamous spinal referral form. The reason it's important, if you go right down to the bottom, if you look even further, so yeah, right down the bottom of that tiny writing, this is actually evidence-based. What this form allows the spinal unit to do is to have a person who is not a spinal surgeon triaging that gets the same results as if it were a spinal surgeon triaging. It's been tested in Calgary in Canada, and they got great results out of it, and that's the reason we have it, because it means our spinal surgeons can go off and operate and they don't have to do the triaging, but we still get good results. The other thing is they have virtual clinics. There's all kinds of wonderful things, but I'll let you read about that on the website. And if we go back one more time, and then I'll shut up. I just want to show clinical services, but I want to make sure we've got enough time for our GPs to ask questions. So yes, if we just go back and clinical services, and again, if we just scan down, now, the trick here, guys, is that we've got medical, surgical, and acute and urgent care, I think, from memory. I apologise, it's a little bit tricky. You've got to think about what goes under what. Breast endocrine, it's under surgery, and I suppose that's obvious in retrospect. It's not always obvious to a GP. Have a look through it. There's actually a whole lot of useful information there too, and I'll probably go through that at another stage, but that's really the main things I wanted to talk about tonight because I don't want to overwhelm you.